Well, good morning, everybody. Welcome to our weekly medical grand rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I just need to say that I'm so looking forward to this academic year's medical grand rounds. Dr. Jennifer Ringrose has very kindly agreed to take over planning and putting together our grand rounds. And so I know she's got a great curriculum planned, and I'm really excited to see what's to come. And in our ever present theme of bringing awareness to issues around equity, diversity, and inclusion, I'm really excited to present the topic of today's grand rounds. So I'm going to start by just introducing our speakers. Dr. Zoya Zaim is a fifth-year adult neurology resident at the University of Alberta, one of our own. She completed her medical degree at the University of East Anglia in the UK, and in 2021, she completed her master's in medical education through the Clinician Investigator Program under the co-supervision of Dr. Penny Smith and BJ Daniels. Dr. Mel Lewis, many of you will know, is the inaugural FOMD Chief Wellness Officer supporting health promoting learning and work environments. She's also professor in the Department of Pediatrics and nationally chair of the AFMC Wellbeing Committee. She formerly was the Associate Dean in the Office of Advocacy and Wellbeing for 10 years. Dr. Shannon Rizicki is a general internist and clinical assistant professor of medicine at the Cummings School of Medicine at the University of Calgary. She is the assistant director of physician wellness and vitality in the Department of Medicine and is also the co-chair of the Department of Medicine's Equity and Diversity Working Group. She has a master's in public health and epidemiology and quality improvement, patient safety and outcomes research from Johns Hopkins, and her research interests include perioperative quality improvement and equity, diversity, and inclusion in medicine. And finally, Dr. Penny Smith, our very own clinical neurologist and MS specialist, completed her MD degree and neurology residency at the University of Alberta, followed by a clinical fellowship in MS at the UBC MS Clinic. And after working as a clinical neurologist for years, she wanted to pursue her interest in academic medical education. Her recruitment to the U of A in 2008 enabled this. And in addition to her work at the Northern Alberta MS Clinic at the University of Alberta, Dr. Smith focuses on medical education and MS and professionalism development. She was appointed Associate Dean and is currently the Associate Dean of Professionalism for the faculty in 2017. Very active with the National NMS Training Network for Research Trainee and was on the steering committee for Alberta NMS Regional Research and Training Center. She also works closely with MS Society. Dr. Smith was the co-recipient of a Professional Care Award from the MS Society in 2015 for her work. So without further ado, our topic today is experiences of systemic discrimination and harassment within residency, a cross-sectional study. And I'll hand it over to all of you.
Thank you so much. I'm going to start it off. It is lovely to be with my adult colleagues. I think y'all have very big stethoscopes. It's very impressive. First of all, I just want to give a shout out to the virtual world. So Penny is coming to us from beautiful downtown Toronto, where she's attending an MS conference. And of course, Shannon is hanging out in Calgary from the beautiful Cummings School of Medicine. So awesome to have our colleagues all here today to listen to Zoya's amazing work. First of all, from the viewpoint of the Chief Wellness Officer, this work is incredibly important because discrimination and racism, these are the things that are absolutely toxic to our work and learning environments. And it makes me think about how we have all had such different experiences going through medical school and residency and staffhood, depending on who we are. For me personally, I'm a cis white woman, which comes with its inherent advantages and disadvantages. And I think back to how many times I've been misidentified as cleaning staff or the nurse or the RT or the unit clerk. And I was recalling one very poignant moment in my life. I was ironically at the CPSA Christmas party, and I had just been selected to be the Associate Dean in the Learner Advocacy and Wellness Office. And one of my male colleagues came over to me who knew me quite well and congratulated me. And I said, I was really surprised that I got the job. And he looked at me and he said, Mel, you were totally going to get that job. The chair of the selection committee thought you were cute. And at the moment, I didn't even know what happened. Like, I totally felt like I'd been slapped. Obviously, I'm thinking about it today, well over a decade later, but I didn't have the language for it. And I didn't know how to respond. And I think, or I'd hope that I would respond differently now. And it just makes me realize how important Zoya's work is. Because if we can't identify and acknowledge that racism and discrimination continues to haunt our clinical and academic spaces, we can't hope to vanquish it. So I really applaud Zoya's work. It comes with some vicarious trauma for sure, for the researcher, for the participants, for those of us in the audience who are thinking about our own experiences. So I just want to remind you, there's lots of support around this place for learners. There's Cheryl's office, the Office of Advocacy and Wellbeing. There's the PFSP. Cheryl and I always love folks to shout out at us and debrief issues. So just know that we're here. Because the bottom line with this important research is that we want to be able to bring our whole selves to work and expect that we're going to have safety and equity and inclusion. So with that, I'm going to call upon Zoya to go through her amazing research. Zoya.
Thanks, Dr. Lewis. Hopefully everyone can hear me okay? Actually, do I need to be wearing this microphone, or is it okay to? Okay.
As long as people can hear in the back.
As long as everyone can hear me, that's fine. Okay. So thank you, Dr. Rakito. So good morning, everyone. I think I know most people sitting here today, but in case I haven't had the chance to meet you yet, my name is Zoya. And I started residency circa 2016, and I'm now a PGY5 resident, so you guys can do the math. Like Dr. Lewis and Dr. Kassan mentioned, I did the CIP and then had a couple of kids in between, and I'm hoping to give the Royal College later this year. So that's a bit about me. And really the inspiration for this study is back in 2020, I came across Dr. Riziki's article. I had never met her, but I came across her paper, and it was really jarring for me. I'll allude to it later on in the study during my presentation as well. And it was looking at experiences of harassment and racism and sexism of staff physicians here in Alberta. And when I did a literature search for harassment and discrimination at the postgraduate level, I found a few studies in America, but nothing within the Canadian context. And so I reached out to doctors Smythe and Lewis, and I said, I'd like to conduct this research project. And they said, if you're going to be building upon Dr. Riziki's work, you might as well contact her. And I did, and she obliged. And so that's how we embarked upon experiences of systemic discrimination and harassment within Alberta residency programs. There will be instances shared by our respondents of intimidation, verbal abuse, psychological abuse, and even sexual assault. And so if you need to take a break or step outside for a drink of water or leave altogether, feel free to do what feels right for you in that moment. And going forward, this is the outline for the talk. And so interspersed between these categories will be poll questions. Hopefully, if we can get them to work. We did a practice run and they were working. And it's to keep the presentation interactive, but also it's to gain an understanding as to how our audience, both sitting here and at home on Zoom, have experienced discrimination and harassment in the workplace. So to start off with, I wanted to get a basic idea of demographics of our audience today. And so you should be able to log on at menti.com or use your QR code. Hopefully it's working. Yeah, so I think it is working. And so you can see that I've kept the categories pretty broad, and that's because, so just so everyone knows, BIPOC stands for Black, Indigenous, and Persons of Color. I'll be talking about this, the definition of BIPOC later on in the presentation, but I've kept the categories pretty broad because I didn't, they're saying they can hear, but there's no visual. So what we might have to do is, I'll read out what the audience here can see on the screen. So I've kept the categories pretty broad, and that's so that nobody would be able to be singled out here in the audience. So right now, so far, what we have is we have about 13 white males, 27 white females, 11 BIPOC males, 13 BIPOC females. And the numbers are shifting back and forth. I'll give it a few more moments and then go on. So now we have about 29 or 30 white females, 15 white males. So I think some people are able to see the slides via Zoom, and some people are also able to see the Mentimeter. I think others are having difficulty. You're good? Okay. Right. So I think then we'll move forward, and I'll segue into the background for the research. So I alluded I'll answer any questions. Sorry, I'm getting some questions here on Zoom as well. Okay, I'll answer them. Yeah, that's fine. That's fine. So this is the paper that Dr. Zicki authored. It's Experiences and Perceptions of Racism and Sexism Among Alberta Physicians. This was a cross-sectional survey that demonstrated a high prevalence of harassment and discrimination in the workplace for Alberta physicians. And if you haven't had a chance to read it, I would highly recommend having a look. There were over 1,000 participants. And for me, it was unfortunate, but I was unsurprised to hear that BIPOC individuals, especially BIPOC women, held the fewest number of leadership positions and were often less compensated. But for me, what was really shocking and surprising was that these individuals knew that they were answering for a research survey, and they knew that the comments would be published, but they still gave racist, sexist, and homophobic comments during the course of the study. And previous work has demonstrated a correlation between physician-patient racial concordance and improved patient outcomes. And so in 2020, the Health Inequalities Reporting Initiative released data emphasizing that racism has been increasingly recognized as an important driver in equitable health outcomes for racialized Canadians. And so in the US, despite Black, Hispanic, and Native Americans making up 1/3 of the populations, they account for only 9% of practicing physicians. And so one qualitative study examining the experiences of BIPOC residents found 3 main themes. One, despite regular experiences with racial biases at work, there was a reluctance to report these experiences. Residency programs didn't have the structures in place to promote diversity and relied on the racially marginalized trainees to take on these efforts. And residents had difficulty balancing their professional and personal identities. And so while in Canada, we are slowly gaining and gradually gaining awareness around EDI, equity, diversity, and inclusivity, and we're trying to build curricula around these ideals, I think it's first important and imperative to understand the lived experiences of the trainees for whom these initiatives are being created. And so we proposed the first Canadian multi-center study within Albertan postgraduate programs to examine experiences of discrimination and harassment during the residency training. And at this point, I'd like to segue back into a poll question, which is that, do you feel that women and men are treated equally in your department? And I'll just start the Menti poll. So you should have seen a change in the question on your phones. So you can either do this via QR, or at home you can input the code in. I'll give it a few more moments. So we have right now, I think most people are able to see Mentimeter on the screen, but we have about 24 saying yes, 26 saying no, 19 unsure. And a total of about 74 respondents so far. And the next question I want to pose to the audience was, have you ever faced discrimination or harassment at this institution? yes, no, unsure. The next question, while you guys are thinking about this one, will be, if you answered yes for this question, will be to ask what forms of discrimination and harassment have you faced? And I'll be going through definitions of various forms. And in the next question, you can select multiple different options. So we've had, for this one, we've had 64 responses, 39 have said, or 41 have said yes, 23 no, and 5 unsure. Get a few more moments. And then going on to the next question was that if you answered yes for that last question, what forms of discrimination or harassment have you faced? And so you can select more than one option for this particular question. Ableism is a set of beliefs or practices that devalue or discriminate against people with physical, intellectual, or psychiatric disabilities. Sexism is prejudice or discrimination based on one's sex or gender. Racism is a process by which systems and policies, actions, and attitudes create inequitable opportunities and outcomes for people based on race. And ageism is discrimination against individuals or groups on the basis of their age. So we have a total of about 94 respondents. I'll just remove the... And so in percentages over here, so about 22% of respondents have experienced sexism, 19% intimidation, 15% psychological abuse, 13% racism. And at this point, I'll be segueing back into presenting our data, but I wanted to do a few poll questions just so that as we're going through the data that the responses that our postgraduate learners gave, that we're also reflecting and introspecting and doing a pulse check on our own department experiences. And then in terms of our methodology, we conducted a cross-sectional electronic survey, the Everyday Discrimination Scale, which was validated at Harvard. I've included on the right side the questions we posed to the residents. And this was disseminated at the U of A and U of C via REDCap. And if they answered anything other than never, then they were given a blank space to elaborate on their responses. So we got about 271 out of 1,800 residents responded, so 15%. And out of those, 72% of surveys were completed entirely. So even if only 1 or 2 questions were unanswered, then we didn't include that in our data analysis. In terms of the demographic data we collected, we asked them what university they were from, the U of A, U of C, race and or ethnicity, gender, and their specialty. And so in terms of our definitions, race, as we defined it, was a socially constructed identity based on skin pigmentation and cultural ancestry. And for the purposes of our study, it was based off of participant self-determination. And we used a term persons of color, which is a heterogeneous group of people who experience racism, exclusion, and marginalization based on the color of their skin. And so we combine this heterogeneous group of people more to protect the anonymity of the residents. So for example, if there's one Black neurosurgical resident in all of Alberta, then they would have been easily identified. So we lumped them together, but in doing so, you also lose some of the diverse lived experiences. And so how do you really compare the discrimination faced by a Black individual versus that faced by an Indigenous individual? We also asked about specialty. We did lump in dermatology and physiatry with internal medicine just because the numbers would have been too low to do a subgroup analysis on those specialties in and of themselves. In terms of our demographic data, 67% of our participants were from the U of A and 33% were from the University of Calgary. And then in terms of with the specialty breakdown, the majority of residents came from family medicine, public health, 22%, internal medicine was 18%, and surgical specialties was 20%. And then in terms of breakdown by gender, 35% identified as cisgendered male, 62% as cisgendered female, 0.5% as non-binary, and 3% prefer not to answer. And then with ethnicity, white, 53% of the respondents identified as white, 39% as persons of color, and around 2% as Indigenous, and 6% preferred not to answer. Going on to the questions that we posed to the residents themselves. The first question we asked was, how often have you been unfairly humiliated in front of others at work? So 42% of individuals noted that at least a few times a year to once a week or more, they had been unfairly humiliated in front of others at work. And based off of, so with each question, if any subgroup analysis stood out, then I'll be sharing that with you as well. So with this question, when we looked at the subspecialty breakdown across the board, over at least 30% of residents felt they were unfairly humiliated in front of others at work, at least a few times a year or more. That was through all of the specialties. But in particular, now focusing on surgery and internal medicine were the only specialties entering into the red zone, with the highest percentages of individuals experiencing it a few times a month or more. And so the next question we asked participants were, how often do others assume that you work in a lower status job than you do and treat you as such? Kind of what Dr. Lewis was talking about earlier as well. The only note I want to make here is because we disseminated the survey verbatim, because as it had been previously validated, had we written the question, we might have phrased it as, how often are you misidentified as work or identified as non-physicians? But we administered it as verbatim how the survey was validated. And so 69% of respondents noted at least a few times a year to once a week or more, they were being misidentified at work. And then like when we break it down by gender, cisgendered males, 36% of cisgendered males versus around 90% of cisgendered females were misidentified at work. So females were 2.5 times more likely to be misidentified as compared to their male counterparts. So how often do you feel that you are ignored or not taken seriously at work? And 56% noted that at least a few times a year to once a week or more, they felt ignored or not taken seriously. And then when we break that down by specialty, so surgery, emergency medicine, anesthesiology, pediatrics, and psychiatry, also internal medicine, over 50% of respondents noted that they don't feel taken seriously at work a few times a year to once a week or more. Surgery and anesthesiology stick out as the specialties with the highest percentage of respondents experiencing this once a week or more. Now, this question and the next question will sound similar. This question is asking how often do supervisors or colleagues direct racial or ethnic slurs at the participants? The next question is asking how often do they hear racial or ethnic slurs used around them? So for this, about 12% of participants noted that at least a few times a year to once a week or more, they were having racial or ethnic slurs directed at them. If we break this down by ethnicity, around 27%, close to 1/3 of persons of color were experiencing this at least a few times a year to once a week or more. Then when we break it down by specialty, the ones that stood out were 21% of family medicine residents versus 14% of internal medicine residents versus 13% of surgical residents. Notice this happening a few times a year or more. This question is asking how often were racial or ethnic slurs used around you in the workplace? So 36% of respondents noticed that at least a few times a year to once a week or more, racial or ethnic slurs or jokes were being used in the workplace. And what was interesting for me was when we posed the question, I was thinking that it would be in context of co-workers or co-residents, but it was a lot of the comments we received when we go through our qualitative data were actually that the ethnic slurs or jokes were being made at the expense of patients, and in particular Indigenous patients. And then when we break this down by ethnicity, around 1/3 of persons of color versus 39% of white respondents noticed that this was happening at least a few times a year or more. And when we look at specialties, 56% of surgical trainees versus 38% of emergency medicine trainees versus 36% of radiology trainees noted that at least a few times a year to once a week or more, colleagues were using racial or ethnic slurs or jokes in their workplace. So our data was non-parametrically distributed and was reported using medians. The higher the value, the least equitable the workplace for the participant. Crisco-Wallace and Wilcoxon ranked some tests were used to compare measures between the demographic groups respectively, and data analysis was conducted using Stata. And so when we're talking about these experiences and using Likert skills and making them numeric with these analyses, it's likely not valid, because if never is 0 and once per year is 1, then is that really the same numeric distance between a few times per month and a few times per week or more? And so we're emphasizing that these are not exact numeric skills, but it's just to give an idea of how respondents are experiencing their workplace. And what's interesting here is the spread of responses in the BIPOC categories. You can see the big spread. And this could be, we hypothesize that this is because this is a really heterogeneous group of individuals. And we're trying to lump together the experiences of Asian individuals and Indigenous individuals and Black individuals, or like a Muslim Hijabi individual. And the way they experience discrimination in the workplace is so different. But we couldn't plot the Indigenous respondents separately, just because we only had a few respondents from that demographic, but just as a discussion point. So in terms of qualitative data analysis, as we talked about earlier, if respondents answer anything other than never, they were given a blank space to elaborate on their choices. And then responses were coded inductively using framework analysis. We went away, each team member went away individually, coded independently, and then we met up and met, and codes were grouped and defined to create an analytic framework, which was applied to all comments. And then in terms of response breakdown, so the questions that we received the highest number of comments for were the first 3 questions. So feeling humiliated at work, being mistaken as a non-physician, and feeling ignored. And then I'd like to draw your attention to the subdivision of comments under misidentified at work. So 75% of women left comments versus 26% of men. And then going on to our thematic analysis, the theme of hierarchy within medicine was quite prevalent within the commentary that the comments that residents sent us or noted down. And so the first sub-theme was normalization of behavior. So we had quite a few residents saying that as residents, this is part of our job, that we shouldn't be expected to be taken seriously. And especially as junior residents, we're expected to, these are the jobs we're expected to do. First comment, it's called residency. The idea that trainees always need to be taken seriously comes from a mollycoddled victimhood society. I'm a resident, so I get the crummy jobs. I hope you do not assume that people answering yes to your very broad questions are evidence of widespread racism and sexism in healthcare, which is just not true and disrespectful to assume. Then there was this, many residents felt that they couldn't speak up regarding their experiences. So junior residents' opinions are rarely taken into account. We have created a culture in which you can never question your senior staff, or it is taken as if you're questioning them as a physician. Also, in policies regarding residents' well-being and education, our opinions are rarely taken into account. Pimping in clerkship or off-service rotations, an anesthesiologist who was a bit sexually inappropriate, standing too close, brushing my chest while in the OR, verbally shamed to the point of tears. And then and I'm assuming everyone knows what pimping means, but it's different than what the colloquial use of it is. So so it's an acronym, put in my place, and there's different definitions, but basically repetitive questioning in a which can make the resident feel humiliated, demeaning for the resident. And I wanted to explain that because I think pimping comes up later on in the comments as well. And then in terms of verbal psychological abuse faced by the residents, we received a lot of comments. Unfortunately, we can only include so many, but comment number 1, a staff yelled and made inappropriate comments about my intellect. I had one staff for 3 months who repeatedly made demeaning comments to me during that period of time, calling me his secretary, exec, admin assistant, thinking it was a joke. And then we had numerous comments as well around shame-based learning. Monthly, sometimes weekly for the past 5 years, often shamed in front of other learners, patients, and sometimes the entire department. Often preceptors don't know what questions to ask residents, and it can quickly turn into a rapid fire pimping session. I wouldn't necessarily call it humiliation, but there are instances when a colleague or staff tries to embarrass you for an answer provided at rounds, for example. The next overarching theme that we want to discuss was the misidentification of cisgendered females. And so it was interesting, actually, based off of their ethnicity, they were misidentified in different ways. So white women as a whole were more likely to be misidentified as nurses or as allied healthcare staff, whereas those from the BIPOC categories were more likely to be misidentified as housekeeping and also nurses. But white females were less likely to be identified as housekeeping as compared to their BIPOC counterparts. Most people do not expect a Black woman to be the doctor on call. They think I am from housekeeping initially. I'm a petite Asian female. I frequently get mistaken as a nurse by patients. I frequently get asked, when is the doctor going to get here? And then by colleagues, routinely mistaken for a nurse or other allied healthcare worker. Most recently, OR staff were confused that the respiratory therapist was putting in a chest tube. It was me. I had been working with them for 2 months already. And then by patients, daily assumed to be a nurse or cleaning staff, even after doing an entire history physical and presenting a plan to the patient and introducing myself only as a doctor and handing them my card. And then there was the overt discrimination and harassment faced by cisgender females, IMGs being international medical graduates who may have trained abroad, but are doing their residency or fellowship here in Canada, and Indigenous patients and residents. So in general, women residents, female residents felt that nurses or patients do not take their suggestions as seriously as their male colleagues. BIPOC residents felt that attending physicians do not take their suggestions as seriously as their white colleagues. Women felt that they had fewer opportunities to work independently and were scrutinized more than their male colleagues. And IMG and BIPOC cisgendered women watched more closely than CMGs or white residents. So in terms of overt discrimination faced by women, similar to prior answers, but even the nurses have said this to me after rounds. Wow, they really question and critique you guys so much more than they do your male residents. Often, my male colleague's opinion is given precedence or my ideas are attributed to him. We'll say an idea or statement that is brushed off only for the same thing to be said by a man later to much praise. Sexually harassed, and the department did nothing. We got a few comments regarding reverse discrimination as well. One of the comments was disparaging remarks against white males is becoming commonplace. It is an easy piñata for my female colleagues who are now the majority to use. In terms of discrimination against IMGs, several people make negative comments about Africans. Also say they are surprised I'm as competent as I am, as quote unquote, all the babies die there. An internal medicine preceptor once advised that, in quote unquote, that's maybe how it's done in the third world, but not in Canada, even though the management plan was eventually the same. If I make an error, I'm incompetent. If my white colleague makes an error, it's a mistake. So for BIPOC cisgendered women, harassment often included racism, racial microaggressions, or discrimination based on being an IMG. There's a few other comments I didn't put in the table, but made by BIPOC cisgendered women. Comment number 1, comments usually from staff attending, such as, I don't understand your accent. Do you even speak English? Or subtle things such as not knowing how to pronounce my last name, even though I've been working with them for 5 years. Received disrespectful comments, primarily from male preceptors, about how as a woman of color, I was trying too hard or being too assertive. And comment number 3, when informing a preceptor regarding my background, which was coming from a third world country, studying medicine abroad, and years of experience, she stated, well, at least you speak good English. In terms of this discrimination faced by Indigenous patients, I spent my last year of residency doing extra training in addictions works. Through this work, I have been privy to various healthcare workers making racial or ethnic slurs or jokes regarding our Indigenous patients. Many jokes are made surrounding Indigenous people, especially at the hospital, where they serve a higher number of vulnerable and Indigenous populations. Generalizations like drug addicts. And I didn't include them in the table, but there was also a couple of comments from BIPOC cisgendered women. Comment number 1, they called chief a lot, been told to stay on the reservation, have had ceremonies be poked fun at, and often meetings are referred to as powwows. Comment number 2, never directed at me because I passed for white, but I've had supervisors say derogatory things about Indigenous patients and families. And then there was a theme of microenvironments. So sub-themes there were how off-service versus on-service residents were treated. And then there was also with a whole culture within the OR and surgical specialties, and we received so many comments about that. I'm hoping to present to their rounds as well. But for the purpose of today, I've included a couple of comments to really make the point of what surgical residents are going through. So on off-service rotations not emerge, we'll do scut work that keeps the service running, but that the surgical residents don't want to do. And in terms of for culture within OR, been yelled at in OR with negative put downs for surgical technique, instead of providing constructive criticism, was asked how many men I slept with to get into my residency program, more as a medical student than as a resident. I've had staff throw things at me, mock me. I was once told I'd be a quote unquote shitty doctor by an anesthesiologist. Now as a resident, it's usually more just snide comments and snubs. And I want to pause there because this last comment really shows the how this particular individual experienced abuse as a medical student, and then now as a resident has become desensitized and really minimalized what he's saying are just snide comments and snubs. And with that, I also want to go back to the first slide where it says an anesthesiologist who was a bit sexually inappropriate, and the description of that is, in my view, blatant sexual assault. Later on under shame-based learning, where it said, I wouldn't necessarily call it humiliation, but there are instances where a colleague or staff tries to embarrass you for the answer provided. And so the question becomes, in what workplace is that considered a bit sexually inappropriate, or is it considered okay, or it's considered that it's not humiliation when someone is trying to embarrass you for questioning, or are snubs or snide remarks considered or used? You can just say this is just what somebody is saying, or minimalized in that way. And so I wanted to go on and segue back into so the people who answered yes to the previous poll question, and I'll start the mentee, did you report what you experienced, if you did experience discrimination, harassment to the university? And while you guys are thinking about this question, the next question is, if you reported it, did you feel meaningful action? Question. So far we've had 20 responses, and I'll switch to percentage. So around 20% of individual, close to 20% reported formally. Between the other, about 80%, 30% didn't report to anyone, and 50% mentioned it informally, but chose not to report. And we'll move on to the next question. Is that for those that did report, did you feel any meaningful action was taken? I'll switch over to percentage mode as well. So we've had 12 respondents so far, but 13 respondents. So out of the people that reported for the last question, around close to 80% said no action was taken, and around 15% noted that action was taken, but they did not think it was enough. And then the last question that I wanted to ask was, for those that chose not to report formally, so the ones that answered no for that question, that other question, what kept you from reporting formally? Was it a fear of retaliation? Was it any concerns about effects on academic promotion? Was it because you didn't think it would be taken seriously, or other? I'll just give a few moments. So for 32%, it was a fear of retaliation. For 26%, they were concerned about effects on academic promotion. 20% of respondents thought that their complaints wouldn't be taken seriously, so chose not to report. And 22% had other reasons for not reporting. And so some people may be wondering, what's the point of polling the audience? And for me, again, I wanted to present our data, but I also want this to be a springboard for discussion and a moment for introspection, reflection, and taking a pulse of our own department. And as I segue into the discussion, I really want us to reflect, because it's apparent to me that this is not just a postgraduate learner issue. This is not a medical student issue. This is not just a staff. I mean, it's happening at all levels of training clearly. And we're coming across the same themes, which are this hierarchical nature within medicine, which number one, there's a power differential. Number two, there is a lack of protections in place for people who do want to report. And so our results demonstrated a high prevalence of harassment and discrimination at the postgraduate level of training within medicine. Despite a focus on EDI initiatives at the U of N UFC, as I just mentioned, the hierarchical structure of medicine limits reporting and normalizes discrimination. And within our resident cohort, cisgendered women and BIPOC participants experienced an inequitable degree of discrimination and harassment during their training. And then in terms of limitations of our study, as mentioned in the beginning, we had about a 15% response rate. Out of that, only about 72% of surveys were completed in entirety. So the low response rate could contribute to the innate risk of response bias and recall bias, given the sensitive nature of the questions. Also, you're going to have participants who have had outlier negative or positive experiences when you're running a study like this. So they may be more motivated to respond. And so if you're looking at our demographics, so white males were underrepresented as compared to resident demographics in Alberta in general, and BIPOC residents were overrepresented of our study as compared to demographics in the resident cohort as a whole in Alberta. And so it's unclear with this non-response what the effect of that is going to be on the data analysis, but that the harassment and discrimination should be interpreted with that in mind. But despite these limitations, we were able to corroborate the trends that we found in our study with other settings. And then our study was taken in a singular province here in Canada, so it may not be applicable to other settings across the country or in other nations. And then there might be other subcultures in Alberta where experiences or perceptions of harassment or discrimination are different. And so in terms of future directions, I mean, you know, we have EDI committees, we have reporting schemes set up at the division, department, and institutional level, and yet we're still finding that individuals are hesitant to report. We found from the poll that fear of retaliation, consideration of academic promotion, thinking that things wouldn't be taken seriously, and then the people that had reported, about 80% said that nothing had been done with their complaints. And so we really need evidence-based solutions to tackle discrimination and harassment at the postgraduate level. And as I mentioned, the hierarchical structure of medicine needs to be addressed. Twofold: one is that you have the power differential, and two, you don't have protections in place for people who are reporting. And then further studies are needed to really better capture the experiences of residents with intersectional identities, race, and gender. So with our study, we grouped together that persons of color, a heterogeneous group, but really it would be interesting to see if we were to subdivide and get higher numbers, what each of the individual lived experiences with discrimination would be like. And then prior to concluding, I wanted to acknowledge and thank numerous individuals without whom I wouldn't be here today. The research team, Drs. Riziki and Lewis, who have been phenomenal research mentors, couldn't have asked for a better research team, provided help and support. Dr. Riziki and Dr. Lewis were messaging me at all time, whatever time of night last night. Dr. Lewis was here first thing in the morning. Dr. Smythe, who has mentored me not only through this research project, but also through my master's and through the last 8 years of residency. So I'm really grateful for that. And Dr. Derek Blackmore, who helped with statistical analysis. And then on a personal note, grateful to all the people who have mentored me over the last 8 years. First, I'd like to thank Dr. Vijay, not because he's here, but I didn't know he'd be here. But I was fortunate enough to have met him in my first year of residency and worked with him, I think, circa 2016. And just his approach as an educator really had a profound effect on me. Later approached him when I was having some difficulties with my master's, and he just devoted so much time and effort, really dedicated himself to getting me through my master's, through COVID, through having a couple of kids in between, and with very little benefit to himself. And for me, mentorship is so it's beyond the professional. And so anyone who knows him personally can attest to the remarkable approach he has to faith and family. And so I'm really grateful to him for his mentorship. And the neurology residency program in the division for their support through the last 8 years. It hasn't been easy. It's been a long journey, but I want to thank the whole division, and particularly I want to thank Doctors Cecile Fan for all her mentorship, her support, her guidance throughout these years. Doctors Ba, Johnston, Kamacholi, Blevins, Nowatzki, Giuliani, and Dr. Smythe I already mentioned, but just the whole division and their support and understanding through this journey. And then I would be remiss if I didn't thank my family. They surprised me by coming out, and I have I didn't know they were coming, but I have amazing supportive spouse and in-laws who are here today. And then I'm grateful to my parents, really, because I talked about my inspiration for the study, but the reason I'm interested in this work as a whole is just seeing their struggles as new immigrants to North America, and just made the sacrifices they made with their own dreams so that we could be here today. So this is a photo from circa 1993-94. He's a qualified physician from Pakistan working as a parking attendant to help support the family, and she's about to start a job as a lab assistant to support him through his PhD. And you know, they worked really hard, and 3 decades later, things have a way of coming around, and this is done with their grandkids. So again, I'd like to just thank them. I'm indebted to my in-laws and parents for everything they've done. And then at that point, I'd like to share, these are my references, and I'll open it up for questions and comments. Doctors Riziki and Smythe and Lewis are here to participate in the panel discussion. And as well, I do have an option for anonymous questions, comments, in case people, I know people have posted so many on Zoom as well, but in case people want to post anonymous.
Stay right there.
Sorry.
You're great.
Thanks.
Thank you. So
Thank you.
You can put yourself out in front of the camera.
Okay.
So on behalf of the department, so I thank you, but I do want to move on to the questions, and I know there's a few online, but I'm just going to start. And you know, this is open to anybody, but we all know that when you know better, you do better. And just in the theme of moving forward and hopefulness, you touched on the fact that there are a number of initiatives, EDI initiatives, whether it's at divisional, departmental, faculty, institutional levels, and so on. And so I wonder if, you know, your group has had an opportunity to reflect on, you know, whether we are moving the needle forward. You know, Dr. Lewis talked about her experience that many of us have had where, you know, a comment gets made and you just sort of, you know, don't really address it or even acknowledge that there was something that was said. And now that we're more aware of it, certainly, you know, your data shows that there is that much more. Do you think, first of all, do you think there's more of it? Do you think that we're moving the needle, you know, in terms of increasing awareness? Are we going anywhere?
You know, I'm going to, because Dr. Riziki has such a great answer for this, and I've heard her speak to this. So I'm going to let her speak because she has a very passionate answer about this.
Go for it, Shannon.
Okay, thank you so much for having us and for having me. When you talk about recognizing and interrupting bias, that's a skill and a behavior. So I really think it behooves us all to take upstander or bystander intervention training, and there are free online and asynchronous programs where you can practice this skill of seeing something, recognizing that this behavior or attitude is problematic or harmful, and then intervening upon it. So it's not always about being like, hey, that's racist, you're a bad person, or even being confrontational, but there are a whole range of things that you can say or do to interrupt that behavior in the moment or after the moment that I think are really helpful. And so I encourage people who are interested in that to participate in a workshop about bystander or intervention or upstander, bystander intervention training. And I think that the amount of discrimination, harassment, racism, anti-Indigenous bias that we're reporting in the literature, I know that people, you know, wonder if it's getting better. I worry that it is not. When I look back in the literature to the 1990s, which is when this type of reporting kind of started, we see about the same prevalence and impact of these behaviors. I think medicine is very behind other industries that have worked harder to get rid of these things, and that's because of the hierarchy and the lack of human human resources and formal reporting. I worry that things have not improved. I am hopeful that the more we talk about it, it will help, but I do think we need better accountability and better culture. So thank you for that question.
Thanks, Shannon. There was a comment in the chat about LGBTQ+ and homophobia. And so I would just encourage you, if you haven't had a chance, for the folks in the audience, we'll make sure it's in the transcript. Dr. Rizicki did answer that question. So I'll throw this one out at anyone who wants to answer here. How do we deal with EDI fatigue among our colleagues' leadership? Many staff and residents do not attend or participate in these discussions because they're tired of hearing about it. And I'll just add to that. I mean, you know, our experience has been, it's you know, preaching to the choir, although we always all have lots to learn. I mean, I learn every day, and, you know, certainly personally, I can attest to the way I treated folks, residents and learners, you know, 20 years ago versus now, and, you know, always thinking about the impact that has on our learners. But, you know, we do always get the same people to the same events. You know, how do we have an impact?
From my perspective, I think there's two types of EDI fatigue. So there's EDI fatigue for the people who are not experiencing harassment and discrimination as commonly. And those people often get tired of being told that they're bad or feeling like they're being blamed or hearing these data, but then not having anything that they feel like they can do. So it's hard to hear bad news all the time and then feel like there's no action that comes of it. And then I think there's the EDI fatigue that comes from people who experience harassment, discrimination, marginalization, and oppression, who are living with these experiences all day and feeling the fatigue that just comes from microaggressions and just feeling constantly dumped upon by the culture of medicine and society, who then are tired of engaging with this work because it's a lot about documenting the discrimination, and then again, no action. So from my perspective, I think things that can combat this EDI fatigue are, instead of always having these dedicated sessions, longitudinally including EDI learning in your materials, in your talks. So having brief EDI moments that focus not just on this is bad, everything's bad, but also saying, okay, this is, I've talked about inclusive vendor policies. Have we talked about how to avoid appropriation? Have we looked at prevention of these things? Looking at EDI as something we can learn about longitudinally, rather than just always, like, you know, get a big, massive dump of information about how bad things are. And so that's one way. And then, of course, you need structures and policies to kind of scaffold these learning events. So making it easier to do the right thing, rather than just expecting individuals to always be monitoring their behavior and improving, would be my suggestions.
The drip
I was going to add in on that, actually, that I think there's a power of bringing it into the informal day-to-day workplace, where it's not about formal and sort of, you know, inputting as formal things for people, but just making it a part of the conversation. Like, how much richness have we had around, you know, people bringing up like EDI perspectives on like a clinical presentation or an experience that a resident has had. And then we all kind of become more aware and do this through an informal kind of community discussion. So I think that there are positive aspects to talking about this more and making it, if you think about it, it's kind of like the seatbelt culture, right? Like, none of us were into seatbelts. Some of us were early adapters and got onto our seatbelts right away. But then you look further on and we all pretty much wear seatbelts now, right? Like,
bicycle helmets is the one I remember, Penny. Are there any questions in the audience before I go to additional?
Yeah, just to follow up, I do think it can be overwhelming to hear all the issues and how do we tackle it. And I agree, the drip model is the best. So is there any literature on, like, let's just tackle one behavior, pimping, for example, and like do it organization-wide, for sadly like a 3-year period, see if we made a difference and then move on. Because that's the thing I'm always struggling with is like, how do we tackle this?
So those at home, if you didn't hear, BJ's question was really around, how overwhelming it can be with all the behaviors that we observe. Is there any data that suggests just addressing one behavior? He used pimping as an example, and just sort of go at that for a number of years. And, is there evidence that will make a difference? And how do we address sort of this overwhelming issue? I don't know, Shannon, Penny, Mel, any of you want to address this? Mel's going to come up, so.
Well, I think the issue, I take your point because I feel we've not moved the needle and we're getting frustrated, but I think of the carnage and the harm that's being caused if we don't address it when we see it. And honestly, I think one of the biggest issues is I talked about it in a talk earlier this week about leadership development, like in undergrad and postgrad, we have to do that deliberate teaching so that when the senior resident is in internal medicine rounds and a staff drops a big old microaggression and you can't speak to it because you'd really like a job at U of A, at the very least, you can take your group aside and say, okay, that wasn't okay. Are we doing okay? So that you feel like you have some agency to act, but we have to give that very deliberate embedded teaching. And I always feel bad because I am so grateful for my learners because they have pulled me along on the EDI journey. And I worry for my colleagues who didn't have that deliberate teaching. We didn't talk about it in medical school. We didn't talk about mistreatment at all. So we are behind as faculty. So we sadly have been relying on our learners to kind of move us a little bit farther along, but I think that's key. It's got to be leadership training at all levels. Thanks, Mel.
And we do this in, oh my goodness,
Go
sorry.
ahead, Shannon, go.
I was gonna say, we do this in Calgary now. So we know that DRIP longitudinal education model is better in medical education. And we know that sitting through a 2-hour lecture on like alveoli and surfactant is overwhelming to learners. So in Calgary, we've developed these EDI moments. And so we do them in our leadership meetings in the Department of Medicine, our monthly like department heads, IMRP, that meeting. And we spend about 10 minutes reviewing a single EDI related concept. We send out either like a paper or a material beforehand, and then we make a little card with references for later if people want to go back to it. We spend the first 10 minutes of that larger meeting just talking about whatever topics that people can build their literacy and competency for EDI related topics. And we find that kind of DRIP model is helpful in a lot of ways. So you learn a little topic, it's brief, and then it continues over years. So you kind of get better at these topics. It's kind of like a safety timeout at the beginning of like a lab meeting where it really communicates that our culture is about safety. Safety is the first thing we talk about. In our Department of Medicine, the first thing we talk about every time all the leadership get together is an EDI topic.
And that ties very nicely with what Dr. Lewis said as well, in terms of, starting with leadership and then pinning down and so on. We only have a couple of minutes, so I'm just going to tackle one quick question, which is something that comes up over and over again that many of us have experienced, which is the piece around the discrimination from patients. So how do you tackle that? How do you move forward on that? We've all experienced it, and we know it continues. Any little morsels of advice or anything to help with that?
Shan, can you do your awesome one when you talk about especially patients who may be disinhibited or maybe having dementia and those pieces who are making derogatory comments? Because you have an awesome way of managing that.
Oh, well, I thanks, Phil. I was going to talk about what I do at the bedside because as a neurologist, many of my patients might be disinhibited with their neurologic issues. So again, it's about how you handle the team. First of all, making it safe for learners to report that they're experiencing this regarding patients and families. Then on dealing with it, sometimes I'll have discussions with the patients and I will say to them what is acceptable and isn't acceptable, and that members of our healthcare team are all members of our team. So it's not acceptable to make comments about the support workers that way, things like that. Reporting it through to the charge nurse about that patient, making everyone aware that there is a patient that might have these, for instance, racial issues where they make a number of racial comments about members of the team. Sometimes I've switched out residents from being assigned to a particular patient or family, and then I've taken it over myself in order to redraw the attention and just have the learner not take that experience, because it's not an educational experience anymore. So you can do that either in the moment, after the moment, same kind of thing, and then having it discuss. In terms of reporting to Alberta Health Services is where you would report that. We do have some issues with that. Like, for instance, currently there's no way for medical students to report their experiences online to patient and support about patients. And I think there's a lot of work to do in terms of working with AHS around this, because I don't feel like they have a really good response so far. That's my take on it.